welcome back. Today we are going to take a look at this 30 years old male patient MRI brain. It already mentioned to you that this is a known case of Thalassemia major and presented with some dizziness and headache, so that's why this patient received an MRI brain. But assuming that you do not have any given history, how can we know that this patient is having Thalassemia major would be a very important point for you to know, especially for board exam like FRCR 2B. Okay, so let's take a look at the sagittal plane first. And you can see that there is skull fold thickening, and also the skull base also is a little bit thickened as well, but the most obvious is at the skull fold. And usually you may have heard a term called head on end appearance, in which you see all this vertically oriented dark signal just like septation within the thickened skull fold. Actually, what are they? Actually, they are the thickened secondary trabeculae. This is actually a radiograph or CT findings that you will always come across whenever you are studying Thalassemia major. So let me explain the underlying pathogenesis. And in fact, it is actually also seen on MRI as well, because just some thickened trabeculae, you can see it anywhere, any modality. Okay, so assuming that it is a cortex of the bone, and within it is the medulla. Okay, and within the medulla, you know that there are different kinds of trabeculae forming a meshwork, and then eventually you will have also some red marrow inside the medullary bone. Of course, we have also mentioned previously that actually there is no absolute red or no absolute yellow marrow. There is always components of fat, which is yellow marrow, okay, and also hematopoietic cell, which is red marrow. They are actually just different types of proportion, and red marrow we expect to see more hematopoietic components. Okay, so even in this patient, you can still appreciate that, okay, so there is some portion of the marrow signal are relatively dark, okay, so I would expect they are the hematopoietic component more, okay, while you can still see some interspersed slightly hyperintense signal, okay, so I would suspect they are actually fat components more, okay, so even though there is anemia in these patients and you expect there is hyperplasia of the hematopoietic components in order for the bone to produce more red blood cells to compensate for the anemia. So this is the pathogenesis. So you will expect, okay, so everything, especially the hematopoietic component, will actually hyperplastic and they will expand the bone, okay. But this is just the superficial portion of the story, okay. What is more important is that, okay, whenever they expand, okay, actually the trabeculae that we have just mentioned, the yellow one, okay, are having two types of trabeculae. One is called primary trabeculae, and another one is secondary trabeculae. So basically, we have different types of trabeculae, and both of them should be present in a normal bone. But whenever we have expansion of some marrow components due to anemia, they will actually break the secondary trabeculae, and the remaining supportive trabeculae, what we call the primary trabeculae, okay, they will hypertrophy. For example, you have two cortex here, and we have the primary trabeculae which is supporting the bone like this, and we also add additional one, they are called secondary trabeculae, as they are less important, so they are thinner, okay, less supportive, but they usually will be present in normal bone. Whenever we have expansion of the marrow and then we break all this, okay, so the stress onto the primary trabeculae are actually will increase, okay, and they will further thicken, okay. So this is the most confusing part. On one hand, you know that there should be some marrow expansion, then the trabeculae should be broken, Then why we still have this hair on end? Why they are not broken? They are even thickened, okay? Because we are talking about different types of trabeculae. When you are thinking along the line of breakage of the trabeculae, you are mentioning that the less important one, more thin secondary trabeculae, while the primary one, they are not broken. Instead, because of the broken secondary trabeculae, they take up all the role of supporting the bone, so they need to be thickened, okay? So this is the hair on end appearance, okay? Underlying pathogenesis. So whenever you have thickened trabeculae, they can even be appreciated on MRI. Why it is that severe? Because in usual MRI brain, you cannot see the trabeculae, they're too thin, okay? Usually the MRI brain, we are doing it in a relatively thick slice, okay? So you should not be able to appreciate the trabeculae unless they're thickened, like here, okay? So you should have this sense, okay, in your mind whenever we see them. So basically they're really thickened, okay? And they are really relatively dark, okay? But they're still interspersed fat, okay, in between those hematopoietic components, okay? So basically they are hyperplastic marrow, especially hematopoietic components, in order to produce more red blood cell, okay, in chronic anemia. Why we know that it is chronic anemia? Because all this hyperplasia takes time, okay? This should not be something that can occur within a short period of time, okay? For example, acute bleeding, you also have anemia, but you cannot ask the bone to produce and then having more red blood cell within a short time. They need some time to adapt it, okay? So, there are second important point would be, can you see that, okay? The occipital bone and also the clivus, they are actually relatively spared, okay? You can see there is some kind of transition and suddenly you see there very thick scaffold, okay? But mainly spared these two parts, okay? These two parts, as we have also mentioned previously, they have relatively little red marrow, okay? Here we are not converting the fat into hematopoietic cell, we just make them hyperplastic, okay? So that means if they have little red marrow originally, even they are hyperplastic, they won't have much significant bone marrow expansion. So this is a very important clue, okay? So this is also a very classic sign that you can notice, which is supporting that all those bone marrow very diffuse, okay? They are actually responding to anemia, chronic anemia, okay? And you can also appreciate that actually the facial bones will also have this kind of bone marrow expansion. Sometimes the sinuses will also be obliterated. So let's take a look at the axial plane as well, okay? So the sinuses here are still okay, but you can see that the bilateral maxillary sinus are actually less aerated, okay? But what are they? They are actually bone marrow signal, okay? Bone marrow signal. So actually they are not usual retention changes. As you can see, they can be attenuated in fat saturated sequence, just like other normal marrow, okay? So they are not retention changes, so be careful in the interpretation, okay? And sometimes this kind of patient, whenever they have scaffold involvement, you know that there are many foramines for the cranial nerves or even jugular vein and artery, okay, to pass through, so that they can transit between the intracranial and extracranial compartment. And if there are hypertrophy involving a skull base, then they can be traumatized as well. So it is not surprising that they can present with all kinds of cranial nerve palsy, okay? So whenever you come across a chronic anemia patient, okay, for example, finally, you are given that they have a chronic Thalassemia major, okay? So what is the implication whenever you can see all this of marrow hyperplasia? Actually, that means if this patient is already having treatment, the treatment should be suboptimal, okay? Otherwise, the stress should be removed and the hyperplasia will gradually dampen, okay? And should not have this kind of thickened scaffold like this to this extent at least, okay? So this is exactly the implication behind. Okay, sometimes the bone confinement is not enough for those hyperplastic marrow. They can grow out of the bone. Okay, what we call the extramedullary hematopoiesis. Okay, so next time when you have other region, take look of whether these bone changes are generalized, because we are not going to only ask the skull fossa to make the bone, make the red blood cells. Okay, we will ask the entire skeletal system, especially the exoskeleton, which have majority of the red marrow, okay, to having hyperplasia. Okay, so we should not be very localized bone changes. And some of the exoskeleton, like the clivus, like the occipital bone near the foramen magnum, they are relatively spared, and also they will involve the facial bones and sometimes may partially obliterate the sinuses. Okay, all these features are actually very classic, okay, for chronic anemia. But of course, apart from thalassemia major, another important differential for chronic anemia is sickle cell disease, and we should always notice for any bone infarct causing X-shaped vertebra, but the included vertebra that is within the schematic is not very sufficient, so we do not have much evidence for that. Okay, so back to the brain, is there any abnormality? So apart from some maybe chronic lacunar infarct, we did not really see much abnormalities here. Okay, but mind you, as we have mentioned, the skull base involvement may compromise the vessel. At least in T2 weighted sequence, it is a good sequence for us to appreciate for any preserved flow related signal void. And here we can still see a pretty good flow related signal void, at least, okay, as the carotid canal. Okay, so which is a very important clue, okay, or important thing to comment in this kind of patients. So at least we know that this patient is not having a optimal treatment and should at least adjust for the regime. Whenever already having any treatment, it is still suboptimal.